베링거-잉겔하임 싱가포르에서 오셨는데 Dr. Luke Lin, Regional Medical Affairs Lead Oncology입니다. The title of his lecture is Innovation in Oncology Research, Strategy and Approaches for Taking Cancer On. The lecture time is 20 minutes. Then we can get 5 minutes discussion time. Let's please keep the lecture time 20 minutes. Please.
Thank you, Professor Kim. Thank you, organizer, to invite us. And to be honest, this is the first time we were invited to share our oncology strategy and approaches. And I need to congratulate Dr. Yon. Did very good presentation, especially you talk about the innovation, approaches, strategy, and also collaborations, and also share some good data over there. And there's something similar. But for me, due to time limitation for my session, I will only give you an overview, a teaser, some top line information. Hopefully we can open up collaboration opportunity. I do see some opportunity there. Okay. This is my disclosure. And again, as previously mentioned, that cancer still is a serious social and economic burden worldwide. And based on last year, the latest data last year from WHO and ACS, you can see the new cases cancer reach 18 million, worldwide. The new cases, and I'm very unfortunate, almost 50% from Asia. So what can we do? How can we do it fast and do it together? And the death cases reach 9.6 million. It's really alarming. Yeah. Okay. So for Boehringer-Ingelheim, you know that it's a family-owned company, and we are planned in generation and focus on long-term success. Yeah. And if you look at that, currently we have 50,000 employees worldwide, and you can see in 143 affiliate companies, and our R&D expenditure across all TA, 5 TA, important one, diabetes, respiratory, cardio, immunology, and oncology, 3.1 billion euros. And 50% of our pipeline are collaboration. That's why I said the key in oncology is combination and collaboration. Okay, now we are really committed to develop leading science to develop transformative cancer treatment that will change lives. And you look at 1, 2, 3, 4 here, very nice indication, 1/3 of assets being delivered in oncology, 1/3. So other TA is the other. And then 2 oncology products have been launched, as you know that. And then also we have 3 research felicities and more than 500 scientists for drug discovery. And of course, the goal is annually we have 4 oncology assets moving into their clinical development. So, okay, now the key pillar for us, we're focused on lung cancer, you know very well, and also GI. And you can see lung cancer, non-small cell lung cancer, small cell lung cancer, large cell lung cancer, and the GI from esophageal cancer until colorectal cancer and anal cancer. This all we cover, yeah? And well, of course, we may have potential cross to others. And as I mentioned, we have 2 products, probably some of your colleagues are already familiar with afatinib and nintedanib have been launched and more than 80 markets globally. And afatinib is for EGFR mutated NSCLC lung cancer as well as later line squamous cell carcinoma. And nintedanib is later line adenocarcinoma only. Okay, now talking about taking tumor on, and we believe strongly, yeah, targeting tumor itself, B at the same time whether we can boost immune system. So with these 2, with this in mind, you need to have at least good cancer cell direct therapy or drugs in the pipeline, and also immune cell-direct therapy, and then you find the best synergy to combine them. Then you can achieve that goal. Yeah. So what do we have? Yes, as you can see, many companies are doing that, and then you look at the pipeline in terms of cancer cell-directed. Yes, we have compounds can block aberrant cancer cell signal. Signal we know like EGFR, the ROS1, etc., and KRAS. Yeah, and also we can induce cell deaths, including immunogenic cell deaths. Yeah, and also we can revert with the compound to revert oncogenic gene expression. And you look at those clusters, KRAS, EGFR, beta-catenin, and PB3, and MYC, etc. We are particularly going on this 4. Why this 4? We consider it as a big 4. Why? And this big 4 you know very well. These big 4 are the most commonly frequent mutated oncogenic drivers. But why undruggable? Yeah. So I explain these 4. Why is big 4 monster? A is, look at the KRAS, is beating heart of the cancer. This is a black heart. We need to turn it down. All right? And then for the beta-catenin, it's very hard. Once you change it, hard to destroy. They need a self-destruction complex. And you look at the PV3, it's a guardian of the genome. And look at the MYC is master regulator. But why this 4 is undruggable? In the past 30 years, no drug had been approved. Because they are not like conventional EGFR, afatinib, very easy. Why? Just like a key that fit into the locks, yeah, on the surface, disease-causing protein. So you just turn it off. Very easy. But for these 4, why so difficult? Because they do not have lock on their surface. And itself need to interact with other proteins through their large flare, complementary, that kind of services. So it's very difficult. You need a new class of drug called protein-protein inhibitor. But now, with the modern chemical process, very nice approaches, we can design a small molecule, like a fragment, attach those proteins, and you find out where is the best, and you create locks. Once that's done, you can develop this fragment into a drug. Then drug can target. So key and lock get fixed. They're called protein and drug complex. And we can visualize them through X-ray crystal structures. Okay, so this is one. But that also explains why another we do big 4. Because if you can successfully target these 4, you almost target 50% of patient population across all cancers. But if you look at our pillar, lung and gastric, you're talking about 80% populations. So that's why, okay? Now, luckily, this is just a quick flash through. I highlight some box over there for the big 4. Very happy, we'll say now that all big 4 compounds, lead compound, has moved into their clinical development phases. And now that you know that, we need first in class, you have robust early phase 1, phase 2 data, and meet unmet clinical need, medical need, you may get a conditional approval. So this how we speed it up. Yeah. Okay, now I just give example for the one of the 4. We did have KRAS specific inhibitor. Yeah, you can go for G12C, G12D, but we also have one SOS1 inhibitor. This is provide pan-KRAS inhibition. Yeah, because SOS1 regulate KRAS, GDP, and GTP cycles. If you can suppress that, you can reduce GTP-loaded KRAS. So you block the pathway. But of course, you have to be careful. Underneath, there's a MAC. You may have a negative feedback. So that's why the approach you might think of use source inhibitor and a MEK inhibitor have more durable suppression. Okay. All right. Now talking about immune cell direct therapy. We talk about many fours at the beginning, 4 moving to clinical development, and 4 big 4. And now I saw 4 approaches to turn the cold tumors hot. So we have 4, like T-cell engager, already had mentioned, and oncolytic viruses, and immunomodulator, and cancer vaccines. These are the 4 we have lined up compounds and can turn up the heat on tumor. Because these are the tumor, why? They're immunogenic low, because they lack of mutations, few mutations, and they can escape detection of immune system because they have also no killer T cells. Okay, good. Now, same for these, also we have already moved into clinical development phases. I'm very happy, and you can see all this. And I just, again, to show an example, I think many people already have it, yeah, and also know that just DLL3 CD3 bispecific antibody, how to engage. So this is a very interesting antibody you can link to your tumor overexpression DLL3, or on the other hand, you link to the T cells. So draw T cell in and kill. So this is called bispecific. But of course, if you do PD-L1, you have antibody linked to PD-L1, another one linked to GTF-beta. So you make form a bifunctional, means new generation immunotherapy. Immunotherapy, we know that now monotherapy, you can give what kind of response rate? 25, maximum 30%. Majority is still non-responder because tumor is cold. But with that linkage by function, you can double up response rate. So this is called new generation immunotherapy. But of course, if the expert here, you know that binding to CD3, what will cause? Also, there's something you need to consider. Binding CD3 will upregulate PD-1 in immune cells and then PD-L1 on tumor cells. So that's why combination with immunotherapy, you can achieve the better. Okay. All right. So that's why we see the key is combination. Or combination is key. You can see that we have cell-directed therapy and then combined with old approaches, cell-directed therapy, and the chance is much higher. Okay. But of course, you can see that just like PD-1 acts a backbone. Like the old day, we have cisplatin is a backbone. You combine many things, you might achieve very good outcome. And I'm happy to see, and Dr. Yong share that approaches like a marriaging, a partnership. Yeah, so it's very good. Okay. Now, of course, the modern drug discovery is not doing behind the closed door in your company, in a lab. No, it's collaboration. So we open a collaboration, and we have very good network. Collaborate. You look into the US, American, and Europe, and Asia. Yeah, not only companies, institutions, and we collaborate. We collaborate with science. We don't care where you are, right? And we want to speed it up our R&D, drug discovery for more benefit of patients. And of course, in Asia at the moment, we can see, although I mentioned half of the new cases from Asia, we have collaboration in Japan and China, and then very soon we'll collaborate in Korea. But of course, at the moment, we're more collaborating in clinical collaboration in Korea, South Korea. You can see so many studies from phase 1, you name it, to phase 3, and then to the EAP program. Many centers involved here. Right? But we need to collaborate more. And afternoon, you see the section, very interesting, because our Singapore team, one of Singapore team suggests, yes, why you get a cancer, get a resistant, treatment resistant, radio resistant, chemo resistant, it's majority is due to cancer stem cells. Right? So they're working on the model and see something. And also our Korean Institute afternoon will share with you. They talk about cancer cell. When they look into antioxidant pathway, and they realize because the large genome study demonstrate antioxidant pathway mutation occur almost 30% in small cell lung cancer. To decode this unknown role, they do the animal model and set it up, found out something very interesting. Yeah, the KEAP1 and NRGF2 mutation actually increase cancer stem cells. So that ring the bell. So this pathway could be another target. If we can target that, reduce cancer stem cell, what does that mean? You can get much longer survival benefit to the patient. Yeah. So again, last but not least, we also launched called openme.com. Everybody interested, you can register yourself, and inside this OpenMe, we release the compounds in all therapeutic area, including oncology. If you're interested, you can submit in your proposal. You get a free compound to decode the functions of the compounds with no cost. But on top of that, if a good proposal, you may get grant support. Yeah. So today is not only oncology, also metabolic. Or if you're interested, register in and see which compound interests you, including our SOS1 inhibitor is online. If you have a good idea for, I know pancreatic cancer is almost 100% KRAS mutation, right? Colorectal cancer 30%. So if you have some idea, do locking, yeah? So that's why I said we're really committed, want to help to win the fight against cancer. And my contact there, and if any interest, our pipeline, our platform, do contact us, and we can bridge you up and hope we can do something in South Korea as well for drug discovery. Thank you.